Yes, Suresh sir, you can start the program, sir.
Yes, thank you, Dhanapal. Good evening, everybody. Good evening, postgraduates. Today we are going to listen to an experienced spine faculty about a common disorder of spine, lumbar canal stenosis. We have two experienced moderators. One, Professor Nalli Yuvaraj, who is a professor of spine surgery in the Institute of Orthopedics in Madras Medical College. He needs no introduction, of course, because he was the first person to start our spine course. He started with clinical examination of the spine. After finishing his post-graduation in Kilpauk Medical College, he was associated with spine trainings in national as well as in international levels. To name a few, I could say he has undergone a training in France in the year 2008 and 9. He was spine faculty in Hong Kong, and the most advanced, the recent one, that is a unilateral biportal endoscopic technique in Busan in South Korea. To his credit, he has got 45 national and international scientific publications. He has given meritorious orations, Professor M.N. oration in Tamil Nadu Orthopedic Conference, Professor Rajagopal over endowment lecture, and for the award section, has got National Award of Excellence from the Indian Orthopedic Association in Chennai. He was awarded the Best Doctor Award from Tamil Nadu Dr. MGR Medical University. Presently, he is the president of Orthopedic Association of South Indian State. We have great pleasure in inviting Professor Nalli Yuvaraj. We are pleased to invite him to moderate the session. We have another faculty, Dr. Bharani, who was the spine consultant in Apollo Proton Hospital in Chennai. He did his MS in JIPMER Pondicherry. After that, he was associated with various training fellowships, one in IGAS fellowship in France, another geriatric spine fellowship in Japan, minimally invasive from USA. And to his credit, he has got 5 teaching publications and is also a former teaching faculty in CHENNAI Medical College as well as in Pondicherry Institute of Medical Sciences. We have great pleasure inviting you, sir. Now it is over to Professor Nalli Yuvaraj to conduct the session. Thank you, sir. Thank you.
Thank you, Dr. Suresh, for the nice introduction. I think this program had an auspicious and a grand beginning, inaugurated by one senior professor, Prof Aa Devidas from Madurai. And the 11th program is having one another senior faculty, Prof Aa Rajamani, again from Madurai. I think to start introducing Rajamani, I think he's quite is a well-known person throughout Tamil Nadu as well as India. And I think it's our duty to introduce such a senior orthopedic faculty from our state. I think there are a lot of youngsters who will be watching this program, and I think it is important that we get to know our seniors. Professor A. Rajamani had been the professor of spine surgery from Madras Medical College. I think it's very important to state that he was the one who was instrumental in starting the spine surgery unit as Madurai Medical College. I used to say that it was struggled for 13 long years when he succeeded after 13 long years. Based upon that, in fact, we had quoted this unit in Madurai Medical College, and then the spine unit was started in Madras Medical College. So I think he was the person who started the spine surgery units in the government sector. And I think he should also be, we should also say that he is the first spine surgeon for Tamil Nadu, we should say. And personally for me, there are 2 persons who were inspiration in taking up the field of spine surgery. One is Professor K. Sriram, one of the senior orthopedic surgeons, senior spine surgeons of Tamil Nadu. And the second one was Professor A. Rajamani. Adding to his credentials, Professor Rajamani had been the president of the Tamil Nadu Orthopedic Association and president of the Orthopedic Association of South Indian States. And he was vice president of the Indian Orthopedic Association. And he had also been the chairman of the PG Education Committee of the Indian Orthopedic Association. One very important credential which has to be definitely mentioned about Prof Aa Rajamani is that he was the first person to start the endoscopic spine surgery in Tamil Nadu. And he has also been outstanding minimal access surgeon. And he has had a lot of publications to his credit, both national and international. And he has, his papers, his presentations, and his work has won a lot of medals in the state and national conferences. I think we cannot enlist them because for want of time. And with this vast experience, I think I am honored to moderate this session along with Dr. Bharani, one another younger orthopedic surgeon. And we will plan it. I think I would request Professor Rajamani sir to, I think we will stop after the investigations, and then we will have a few discussions. I mean, the questions what the delegates put, and then we'll also would like to ask a few questions on behalf of the postgraduates. And then lastly, we'll have the treatment session. So instead of having it at a stretch, which will be monotonous, we'll just start with the investigation stage and then have some questions, and then we will again continue with the treatment, sir. With this short introduction, without any delay, I invite Professor Rajamani to teach us on the today's topic, lumbar canal stenosis.
Shall I?
Yes, sir.
Where my slides are being shared?
Yes, sir.
Yeah, very good. Good evening to you all. And it's a nice words. Thank Dr. Nalli Yuvaraj. And I thank the entire TNOA office, who are all none other than my own friends, colleagues, juniors, postgraduates, and whatnot. And then I thank the members. And then I thank those members who may not be attending this, but listen to this. I thank them all, and then I thank all my friends who is viewing this. And really, this topic, lumbar canal stenosis, degenerative, and really it's very important for the postgraduates, for the exam point of view, both theory and clinicals. And for the consultants, I know the meeting is being attended by not only by postgraduates, by young junior consultants and aspiring and spine surgeons also. And for the regular consultants, it is a bread and butter. The lumbar canal stenosis or a degenerative disease of the spine is a bread and butter. It is a day-to-day practice. Almost it will occupy, apart from trauma, if you take an orthopedic practice, it will almost occupy 50% of your practice, the back pain, which you come across. So I thought I have to feed both young postgraduates as well as junior consultants. So I am covering this topic with in detail in some areas which may be too good for too much or too good for postgraduates, but they should know it is always better. And it will be very useful for the consultants also. Now, lumbar canal stenosis degenerative, as Nalli pointed out, 1 hour I thought it is too long to listen to anybody. Even if I am going to listen for 1 hour, probably I'll be tired and then I'll either get distracted or go out or something like that. So I have, for the convenience sake of the audience, I have made this into 3 portions. One comprises of the surgical anatomy, the pathogenesis and the pathological anatomy. And then second part is clinical evaluation that comprises of a clinical, radiological, and laboratory. And third one is a treatment, both conventional and the recent advances. So after each part, I break, and the moderators can raise the questions or the floor can raise the questions for 5 minutes, and then we can join again as continue as the clinical evaluation. And this I give earlier because those who see this and plan yourself so that if you want to have a break, skip one session, do skip and then join other sessions. And at the same time, you'll be active so that it will be, you'll be continuously seeing that. But if you listen to all these 3 parts, I think it will be more useful to you. With that short introduction, let us begin the subject of the today. You know, lumbar canal stenosis is not a new condition, not coined now. It is almost 1954. It was defined by Verbiest. If you read this, it is, I just read, it's a narrowing of the spinal canal producing symptoms of radiculopathy or claudication, and it is a common finding in an aging or degenerative spine. It is given in 1954. Still, this holds good. This has given every explanation for the disease or the degenerative problem. You see, narrowing it has been given. Symptoms have been given. I think all of the people who have seen this case will agree. They hardly find any signs to demonstrate, but most of the symptoms will be there concerning to the radiculopathy or claudication. In the aging spine, aging, the degenerative changes can vary from age to age, which you may come across later. So if anyone write to talk about or write about lumbar canal stenosis, you remember this definition written in 1954 and to read in between the lines, you will get an answer. Now to begin with, now it's a border issue is going on in the country, you know. Here you should not miss this. What is the spinal canal border? You know, the spinal canal, you know, everybody know this is the spinal canal. And then the borders, all of you know, it is a bone, mainly bone, the vertebral body, posterior body, vertebral body in the front and both sides of the pedicle, and then the facets on the sides, and then the lamina on the posterior. The border does not stop with this. The next border is a very, very important, which is comprising of a soft tissue. It is called a dynamic, which comprises of the disc, facet joints, and then the ligamental flavum. So this is very, very important because all the degenerative changes mainly happens in this dynamic portion, that is the soft tissue. If you recall, call back again what is the pathology that has happened and which will come across. So nothing happens. Of course, aging changes happens in the bony component, the static borders. But what degenerative changes happens in the dynamic borders only produce problems or symptoms to the patient. And this corner is a very, very important corner, which is hidden here. This portion, the soft tissue portion, we got a ligamental flavum here, inferior facet on the medial side, superior facet is on the lateral side. This is the facet joint capsule. And then the ligamental flavum do not stop here. The deeper part joins to the capsule. So the majority of the problems, what are all the problems or osteophytes comes with the inferior articular facet. It contributes to the central part, and whatever osteophytes or whatever changes that is being happening in the superior articular facet, which contributes on the lateral side. But the ligamental flavum, because it is attached to the facet joint, it takes part in all. Majority of the times we miss the lesions here. That's why it is also called a hidden zone here. Now, what is the shape of the spinal canal? It varies from individual to individual, number one, and it varies from the L1 to L5. From the L1, the anteroposterior diameter is more than the transverse diameter, which is not the concern now, so I didn't show it. The L3 and L4, the anteroposterior diameter and medial lateral diameter is almost equal. And then when coming lower down to the L5, the anteroposterior diameter is reduced and the medial lateral diameter is bigger. This is very, very important. You should understand the anatomy so that it will be made useful for you to plan and do the surgery. So this is the canal which you see here. It is almost trifoil. It is almost a triangular. It's an individual variation of each vertebra, not only each vertebra, but it is the various individuals also. Now, the lumbar canal stenosis, the problem is between the capacity of the canal and the content of the canal. In any carpal tunnel syndrome or any tunnel syndromes, the problem is always either the capacity gets reduced or the contents becomes more because of the pathological. So it is always a tussle between the capacity and the content, and always the disparity. Here, most of the disparity is in container and not in the content in the degenerative. And mostly the problem is with the container, as I repeatedly told. Now, what is the normal capacity of the spinal canal? The normal capacity of the spinal canal usually measured from anterior to posterior, because as I said already, normally the anterior posterior distance do not change. The medial lateral changes happens from proximal to distal. It gets increased. It surpasses the anterior posterior in the lower down. So whatever mid-sagittal diameter you take by X-ray or MRI, it is a standard of 15 millimeter, and it cannot be taken into granted. So whatever the medial lateral diameter is there, nowadays this whole area is calculated. There are all softwares are there. So the whole area is taken to measure the lumbar spinal canal. And normally it is 150 to 200 square millimeters. And this can be measured by MRI with the short wire. Once the medial lateral diameter reduces to 10 millimeter, or when the area becomes less than 100 square millimeter, it produces symptoms, and it is called the spinal canal stenosis. So the symptoms due to reduction in the size of the canal, not only in the size of the canal, it varies from side, the medial side, lateral side, which will come subsequently. So not only the canal size may vary depending upon the site of these various canals, and the symptoms also will vary. Now, next, what are all the contents? Everybody knows the content of the spinal canal, particularly my talk will be containing to the lumbar spine, because the degeneration, even though cervical spine is there, but I am not taking that into consideration because enough to be talked on lumbar spine. So I'll talk upon mainly on the lumbar spine only. So the content of the lumbar canal is mainly the cauda equina, because lumbar canal stenosis is more in the lower. So I take that into the anatomy. It is the cauda equina fibers here, and it is the exiting root and the transverse root, traversing root. So these are all the main three structures, the contents of the canal, apart from neurovascular bundle to the spinal cord. Now, what are all the parts I told you? I told you the degeneration produces the changing in the size of the canal depending upon the area. Now we can't say general in area, we have to divide it into parts. That is, the canal is divided into central and the lateral. Central canal is the one which is to the midline, that is of course to the other side also, the one end of the lateral part of the dura to the other end of the lateral part of the dura. That portion is called the central portion of the canal. And the lateral canal is once again subdivided into a subarticular zone. It is from the lateral border of the dura to the medial border of the pedicle. This is a subarticular zone. Then next to the foraminal zone, it is almost between the superior pedicle and the inferior pedicle. The area confining between the two pedicles is a foraminal area. Then what is the structure lateral to the intervertebral foramen is called the extraforaminal. We have to delineate these three, central and the lateral, all three subdivisions. It is very clearly marked in A, B, C, D here. And then you have to know this because the contents in each place is totally different. For example, and I'll come subsequently. Next important structure is the intervertebral foramen. This is also another important structure which needs a lot of attention. Normally, the intervertebral foramen is described as the pinna of ear. It's shaped like this. It is wider in the proximal and the distal it is narrow. And the border is from anterior to posterior, the disc, and then the inferior part of the body, and then the pedicle, and then the inferior articular process of the proximal vertebra, then the facet joint, and then the superior facet on the inferior side, and the pedicle of the inferior vertebral body, and then the disc. So if you go around like this, it is formed by the dynamic borders as well, and then the static borders. When there is a degeneration, you see it is reversed almost. Of course, the disc contributes. It is more wider in the inferior side than on the superior side because of the osteophytes. This is what you see the foramen in the MRI. Because majority of the times we go by the reports or we see the sagittal plane only and then proceed to a conclusion. Please don't do it. Because there is an important structure which is there. As I told you, it is a hidden zone, which most of the times we don't see or we forget about this and then we come to a conclusion. So this is a very important area, intervertebral foramen. The height is normally 20 to 23 millimeter and the AP diameter is 8 to 10 millimeter. And then there are important structures which is maybe too much for a postgraduate, but if you are going to be a consultant, going to be aspiring to be a spine surgeon in future, better know about the contents of the intervertebral foramen. This can be seen even in a well-delineated MRI. You see, this is the foramen which we commonly don't see, but at least here have to try to see this. This is the intervertebral foramen. You see the shadows here and here, and then there is some bands here. Let us know what are all the bands, why it is significant. This is a portion of the ligamentum flavum, the deeper part of the ligamentum flavum, which is attached to the capsule, facet joint capsule, which contributes to this lateral canal stenosis. So whenever somebody wants to do a lateral canal stenosis, unless you relieve the ligamentum flavum totally, you're not going to release the lateral canal stenosis, the symptoms will persist. Then next, what are all the importance of the other ligaments? These ligaments can go in for a scarring because of the previous surgery, and the patient can go in for a narrowing in the foramen because of the thickening and the scar tissue of this. You see the nerve is occupied in the proximal port of the canal, which is wider, and this vascular bundle is on the inferior part, which is close to the disc. So this is very important because whenever you operate on a disc, sometimes you may not be able to control the bleeding. You'll have a hell of a bleeding, and you don't go and search anywhere. Don't go to the proximal half of the foraminal area. You go to the distal part of the area, you'll get the vessel. If you cauterize, you are safer. So for that purpose, you must know what is the shape of the canal, what are all the contents. It is very equal for the diagnostic as well as therapeutic point of view. So this is, I have just enumerated various ligaments, and the contents of the intervertebral foramen is the nerve root here, along with that still more proximal, the dorsal root ganglion, the artery and the vein. Then the next important is how it gets narrowed because of the pathogenesis. But we must know the pathogenesis. It is nothing but a degeneration. The degeneration starts throughout. It is more pronounced in the lower segment, L4, L5, L5, S1, because this has got more mobility than L1, L2, L3. L1, L2, L3, only 25 to 30% of the whole lumbar spine mobility happens. The more mobility is there, more the degeneration occurs. The effects of degeneration is there. Even though degeneration is equal, the effects of degeneration is more because of the mobility and the overloading. So it always throws simultaneously. And the vertebral joint comprises of the three parts, a triple joint complex. One is the intervertebral joint in the front, and then the both facetal joint on the both sides on the back. It is a triple joint complex. Degeneration starts simultaneously, all the three joints, and one influences the other, the changes in the other, and thereby the sequences also. It is a continuous, ongoing, and it is a progressive disorder. You should not forget that it is a continuous, progressive process, because unless you know, they never give a promise to the patient that you will make it all right forever. Whatever we do, whatever surgery we do, it is only temporary, and then definitely the patient will ask, sir, it will come back again. Please don't say no. It will come back again. It is only a question of 5 years or 10 years and how much you do the surgery. So it is a continuous and a progressive in nature. And then if you carefully observe the majority of the things, if you listen to MRI, this is a multi-segmental stenosis. You see the canal is normal here, and it is narrowed here. The cord is compressed, the neural sheath is compressed here. If you just recall the anatomy which I told you, this border is mainly bordered by the bony element, that is a static element. And what you see here, the compression is mainly going to be the dynamic element, that is the disc, and then this area is called ligamentum flavum or the facet joints. So if you carefully think of whatever changes happen to the regeneration, always symptomatic, is due to the dynamic portion of the canal. Why I stress upon this is because conventionally what we were doing is to reach here, we have removed the lamina and then the spinous process, whole thing, for no fault of them. We sacrificed those and then they reach that. So you should keep it in mind the pathological problem, the culprit is mainly the dynamic part and not the static part, static borders. So changes happens only on the dynamic borders of the spinal canal, and that produces the symptoms. Now, what is the degeneration? Don't think the degeneration starts at 40 years or 50 years. The degeneration starts at the second decade itself. First, the changes occurs in the nucleus pulposus. The nucleus gets dehydrated, and then the annulus neoangiogenesis happens. It becomes hard. It gets crackled, not to bear the biomechanical load, and then it leads to crack, and then it leads to prolapse, and ultimately the disc height will get narrowed. As I told you, the triple joint complex, one affects the other. When the disc height narrows, the simultaneously ongoing facet joint degeneration like effusion, capsular laxity, and then it produces cartilage erosion, leads to subluxation and osteophytes. So these are all the changes gets aggravated because of the disc height is narrowed. Subsequently, there is a degenerative changes in the ligamentum flavum, mainly because of the elastin fiber changes, and it thickens and it gets weakened. Not only that, if all the muscles get degenerated, and particularly the paraspinal muscles are more degenerated than the other muscles because we are having erect posture. Our original posture is a quadrupedal. When we become, this is one of the penalty we pay for the erect posture, something like a disc prolapse, piles, and varicocele or varicose veins. This also degeneration of the paraspinal muscle starts earlier than other muscles, and myopathic changes occur which disrupt the equilibrium of this one. Borders of the spinal canal. Now, as I told you, the disc height narrows affects this facetal joint, and ultimately it affects the this gets lagged. Supraspinous and the interspinous ligaments gets lagged. This takes place both in the sagittal and coronal plane, and it all people, all degeneration do not produce listhesis. You would have seen only some of the cases only you got a degenerative listhesis. That is mainly because of the facetal angle. The facetal angle is more and more anterior posterior. It is more and more oblique, or more and more it is acute. In those cases only you are likely to get degenerative listhesis. On all other cases will not go in for a degenerative listhesis, number one. And number two, the degenerative listhesis will not go beyond grade 2. Something like lytic listhesis where you have got a grade 5. But whereas here, because there is no partial defect, only the laxity of the ligaments and change of this facet joint angle, it cannot go beyond grade 2. That is what you have to remember when you remember the pathological anatomy. So, just to put it in one word, the pathogenesis, the degeneration takes place like this, and then it leads on to the stenosis. And if it is going to be asymmetrical, or it is going to be facetal changes or atrophy, whatever it is, it can go on for listhesis. And if these changes are not symmetrical on both sides, the one side is changes are more, it can produce a scoliosis. And then one is just the pathological anatomy by the way you complete, because as I told you, the central canal stenosis is contributed by the disc ligamentum flavum hypertrophy and the osteophyte of the mainly of the inferior facetal joint, because it becomes medial. So mainly the central canal stenosis involves the cardia equina fibers only. Now coming to the lateral canal stenosis, what are all the contributors? As I told you, it is the disc, and then the lateral osteophytes, and then the superior articular passes of the inferior vertebra, and then the inferior pedicle sometimes, which gets into it when the height of the disc is reduced. Commonly this happens in L5S1. The pedicle migrates into the intervertebral foramen. It contributes to the pathological anatomy. So the subarticular involvement, you see the structures there, the exiting nerve root, the cardia equina lateral border, and then the traversing nerve root. So this is the structure these are all the structures which is compressed by the subarticular portion, and all these symptoms will be pertaining to both nerve roots. Then coming to the foraminal area, the foraminal area mainly contributed by the disc and then the ligaments there, and osteophytes on both sides. But main structure that is compressed is the exiting nerve root. Cauda equina and then the inferior root, the traversing nerve root escape, you don't come into that area. So only the foraminal area, you get only the exiting nerve root is involved. Coming to the extra foraminal, the main pathological anatomy is the osteophytes of the superior mainly. Of course, very rarely you get the osteophytes from the inferior, but majority of the osteophytes of the superior facet only contribute. And sometimes you get facetal cyst also. Facetal cyst from the facet joints can occupy the space here, and it can occupy anywhere in this place in this area. So these are all the main structures that is compressed in the various area. You must know this very frankly. This is just to show you how a pedicle gets migrated into the foramen. See, this is the normal disc, this is the normal pedicle. Once the disc height is narrowed, there is an ascending up of the pedicle into the foramen, and this could be one of the cause for the compression in the foraminal area. And this is just to show you an osteophyte. This is sometimes an osteophyte. The posterior part of the body can occupy the canal or into the center. It can produce the symptoms. And this is just to show you what happens, the contribution of the lateral canal stenosis by the body osteophyte as well as osteophytes from the facet joint. Now, these are all just various radiological, which as I told you, this is one of the pedicle, and this is just an osteophyte on the margin, and this is the ligamentum flavum. And now the compression of the cauda equina and nerve roots, it always produces symptoms: pain, sensory disturbance, motor weakness, bladder, and bowel. How it happens? After all, a compression produces how this damages, not like a mechanical compression, like a trauma or fragment or something like this. When a compression is there, you get a venous pressure, and then the blood flow is decreased, and the extraplasmic flow is also decreased. So ultimately what happens, these are all the changes happen: the edema, demyelination, Müllerian degeneration, the nerve root ischemia, fibrosis, degenerative motor root, and the corticoepiphyseal corticoevocative changes, and that ultimately lead on to all these symptomatology which is shown here. That is how it produces symptoms. It is a progressive disorder, as I told you. It's a chronic, continuous, and progressive in nature. What happens if you leave it alone? If there is a 50% of the stenosis is there for some time, the cortical evocative changes are there, and muscle weakness comes in 2 months' time once it started having 50% of the stenosis. Once you have a 75% of the stenosis for a long time, probably whatever surgery you do, probably the recovery chances are very little, because irreversible changes, which I described earlier, are settled in. So it depends on the age, activities, the pre-degenerative structural status, because sometimes some people, the canal diameter will be less than 15, somebody it may be more than 13. For a 17 mm people, the stenosis needs to be more. The pathological changes has to be more to produce symptoms. So one fellow may get a 40 years pain, another man get a 50 years or 60 years. So it all depends on this, because degeneration is ongoing process, as I told you, from second decade. At any age after that, anybody can get a stenosis. It all depends on the activity of the particular person, and then the previous structural status, and then the comorbidity also. Next, this is the natural history depending upon what happens, which I told you earlier. That is 10% will deteriorate if you leave it from the state 1. But over a period of time, 20% of the symptoms resolve, but 70% of the persists with symptoms. We have to judge which one is that. I think this is one more thing. Dynamic stenosis, one should know. This is normal to anybody. Because flexion and extension of the spine, when we normally do it, in extension, you get a narrowing of the canal, and then in a flexion, it gets widening. Because in extension, you get the infolding of the ligament of flavum, will get narrowed, which normally happens. When already there is a narrowing of the canal, due to that, if an extension movement, the dynamic movement can aggravate it. That's why this normal physiological stenosis, because of the dynamic, we make advantage of this using in the treatment. We ask the patient always to adopt a flexion posture. not only the changes happens in the spinal canal, but also the foramen. You see, this is in the neutral portion, and this is the flexion. You see the height is almost increased 14 to 80% than the extension, and then the width is increased by 20%. So when the patient flexes, then naturally the canal and then the intervertebral foramen gets widened, and the patient is comfortable with that. So now once again, this is the changes we come across, and then you should not forget about this. Now you must know the etiological part of the canal. How many types of canal is there? For theoretical aspect, one should know. These are all the acquired causes: the degenerative, lytic lysis, post-traumatic or infective cause, tumor, metabolic, iatrogenic after laminectomy, scar tissue, fusion or chemonuclear lysis. And occasionally you will get a idiopathic congenital, where the interpedicular distance will be narrowed and in achondroplasia. Very rarely we see a situation like this, but majority we have acquired problems, and of these degenerative dominates. And this is just to recall, these are the dynamic changes that goes on, and just to allow you to recall this picture. I think with this I'll stop. Hello?
Yes, sir.
I think all of you are there. Everybody got bored.
Yes, sir. We are fully awake, sir.
Yeah, thank you. Because it's too long a lecture, people should not sleep and go away. I think now any questions or
yes, sir. I think our postgraduates are gearing up. I think we have not had anything on chat box, but I think we would like to ask a few questions. I think myself and probably Bharani also. I think I will start right from the definition, sir.
Yeah.
So like the definition, you started by saying that this is a condition in the aging spine.
Yeah.
Yes, sir. So, but sometimes we see disc prolapse. Of course, disc prolapse is also a degenerative process that taking place in the spine, in the disc. And in the say 30, 35 years or 40 years old man, having a massive disc, and he comes to us with the presentation of claudicatory symptoms due to the encroachment of the central canal. Central canal, even the foramen also can produce it. So can we strictly say it is a condition which occurs in the aging spine? Can we say it's more common in the aging spine, and it can also occur in, because the postgrad should not go by the view that it's only present in the aged spine. It can also come in the middle ages also. Yeah.
That's why I saw degeneration starts in the second decade, and they didn't touch upon much because already there was a topic on the disc prolapse discussed earlier. So I didn't touch upon that. But as told you, all the discs do not degenerate, and the degenerated discs all are not symptomatic. Those who are all vulnerable, as I told you, the jelly-like material of the annulus goes out. It gets dried up, and the annulus gets hardened. So even an injury, mode of posture, way of working, it gets cracked. So probably a trauma predetermined that. But unless it is going for a degenerative changes, it cannot give way or something like that. So I deliberately not touched on that.
So can we say like it's also like it should, the PG should not think that it is only in the aging spine? Probably they might think it's 50, 60 years only. No, it can also occur in the younger individuals.
It can occur
any condition which can encroach upon the
spinal canal.
In the spinal canal or the foramen, the lateral canal. Yes, sir.
That's why I told it is occupation is disc also in the front.
Yes. And then nicely enumerated, so like starting with the main pathology where it exists, like mainly in the, you showed that the zoomed view about the junction of the ligamentum flavum with the facet joint. Very nicely enumerated. So I think that's one of the most important points that has to be noted. And then the next one was the main pathology is the dynamic component of the spine. I think that is a very nice point. I think which is clearly you spoke about that, sir. And then the one question which I want to ask you is the most often the disc is in the paracentral region, or common disc prolapse in the paracentral region, and we normally have the traversing route which is involved. In fact, the exiting new route escapes before much higher And hence it normally escapes, sir. I think in your thing, I saw that there can also be involvement of the exiting route also.
Yeah, suppose a normal disc, regular disc prolapse will affect always inferior part, that is a traversing nerve root.
Yes.
Because the exiting nerve roots goes proximal to that, almost close to the pedicle. So unless there is a proximal migration of the disc prolapse, the exiting nerve root usually will escape in disc prolapse. The commonest is the traversing nerve root only we get affected. There is sometimes I tell you this question, I think repeatedly attending as an examiner for the regular candidates,
Yes,
sometimes they ask how a disc prolapse can it produce a two disc, they'll ask. Then the candidates will say, no sir, yes sir, they get confused with the exiting nerve root or traversing nerve root. So normal circumstances, a disc prolapse will involve only one nerve, that is a traversing nerve root, is very clear. But a disc prolapse can involve the two nerve roots, both exiting and transverse in 2 or 3 occasions. There is one is when there is a migrated disc prolapse, and the number 2 when there is abnormal nerve roots. That there is a separate classification which I have not gone into the topic because it has been covered by the discipline, they left it. So abnormal roots, 2 or 3 nerve roots suffering from the single one, or there is a furcal nerve. Furcal nerve is additional nerve root that occurs from that and then passing to the foramen. So these are all the 3 occasions only a single disc prolapse can involve more than one root. Otherwise, otherwise the examiner repeatedly asks the postgraduate better not to commit that usually the disc affects 2 nerve roots. It always affects the traversing nerve roots. If they specifically ask somebody like Nalli or myself, because I may not come as a regular examiner, I may come for a diploma. Some people are interested in that, they may ask sometimes, single prolapse can occur in 2. But normally for a general postgraduate point of view, no. For a consultant, it can.
Yes. There is one question from the delegates, sir, here. Prabhu from KMC asked that when mobility increases the degeneration, what is the rationale behind back muscle strengthening exercises, sir? Won't it worsen the situation?
No. Once again, I thought I'll talk it in the conservative treatment. Having asked this question, I'll tell it is strengthening the core muscles of the paraspinal muscles, which maintain the curvature. Normally, when you see because of the degenerative changes, the normal lordotic curve gets altered. So we have to maintain the posture of that because, as I told you, the dynamic stenosis, we make use of that for the conservative treatment. So we are not training all the muscles. We are training a group of muscles, which I will talk subsequently, to strengthen or maintain the posture, which is giving a pain relief to the patient. So normal strengthening exercise will not produce. We don't strengthen all muscles.
No, first of all, another concept which he is saying is mobility increases degeneration. I think that's a wrong concept.
Yeah. Mobility is...
mobility maintains the thing.
Maintains.
Yeah, it's not, they should...
it is in fact one of the findings that mobility gives a relief, something like an osteoarthritis of the knee joint. Patient walks out, sometimes get a relief.
Yeah. So normally, in orthopedics, is a movement is life and life is movement. I think we should not go by the thinking that mobility increases degeneration. It's not like that. Yes.
No, I mentioned because we postgraduate would have mistook. It happens in all places, but it happens more because it is subject to trauma or something like a disc prolapse. We say it is common in L4, L5, L5S1, not in L1, L2, L3. Because more mobility is there, more chances of trauma and more chances of imbalance biomechanically that produce. That may be the cause, but not like mobility increases degeneration. It is prone for trauma, that's all.
I think that there's another question from the delegate. I think you had already mentioned it, sir. How much reduction of canal diameter related to appearance of symptoms, sir? So I think I would like to add to this one. Like, can we strictly say that if it's going to be less than 50%, you will start getting symptoms because the body has various compensated mechanisms. That's what the literature says. And there are instances where we see a severe stenosis also not presenting with any gross symptoms. I think, can we strictly go by that? I think, or is it just a guideline only?
No, we cannot strictly go by...
Developmental stenosis, sir.
Yeah,
Can be even a small decrease in the canal diameter can produce symptoms. So can you just elaborate on that, sir?
No, that's I told you. No, that it is. I mentioned in the lecture. Rightly you pointed out the canal size varies. Once again I told you symptomatology depends on the age of the patient. Pre-degenerative structural changes. What I meant by that is, for example, the canal is wide. The fullest diameter 23 is there. And the 23 is there, probably a 10 millimeter of the obstruction or compression is not going to produce symptoms. Whereas the canal is naturally for him something like a tall man, short man. The canal is going to be only 17. For a 17 millimeter canal by birth, a 10 mm block will produce more symptoms. So just dogmatically, we cannot say it is 50% or 70% like that, because the canal size varies from individual to individual, number one. And number two, once again, the pain tolerant capacity varies from individual to individual. Nature always have a defense. That is why they say 50% of the people, that is, it becomes stationary. It does not progress. So the natural body defense to the compression itself gets the accommodation by the body itself varies. So we can't dogmatically say that. It varies from individual to individual. When you see, sometimes, as you told, sometimes you see grossly by MRI, there is a disparity between the radiology. Canal size we measured by radiology. A lot of disparity between the spine and in the spine, between the radiology and the clinical, rather than in any other condition, any other regular orthopedic condition. Invariably it will correlate. But the spine is always, the mismatch is there too much. That's why it is difficult to locate where it is.
Next one is the question on my behalf. So like you said, that there is an increase in the venous pressure. I want like which venous system? Is it the epidural veins or the veins of the individual nerve roots?
No, it is totally. Because the changes individual nerve root, it is only cauda equina.
Yes,
It is a cauda equina. It do not have any anterior spinal artery or posterior spinal artery, something like a cord. Every nerve root is there. So the segmental artery which is there in the foramen, the obstruction is there mainly on the side. There is a vertical inner spinal chain is there on the inside. So there is no separate spinal artery as such. So the segmental vein plus the vein interconnecting internal communicating veins gets obstructed.
Yes. And lastly, I think one question is the facet angulation. It has got a bearing on who is going to develop a degenerative spondylolisthesis. Normally, what we learn is the orientation is sagittal. In the thoracic level, it is coronal, and in the lumbar region, it is more of a sagittal orientation. Can you just elaborate on that, sir? For example, if you go lower down, the sagittal orientation also varies a little. The role of facet tropism, sir, where the orientation changes.
That's I thought I'll come in I have got the slides there subsequently.
Okay, we can
but just to mention that we have done a study why the degenerative listhesis is more common in which patients. I think maybe 15 years ago, I presented the paper and then published that also. We have studied retrogradely we analyzed. Those are all the patients which had degenerative stenosis and listhesis. We traced back the X-ray and called back them, took a fresh CT and then measured the angulation. The angulation is more and more sagittally oriented than an oblique. It is not pure sagittal, it is not pure coronal. It is in between, maybe 60 to 70 degrees. The more and more the both angle bilateral is more acute. Those patients have that sometimes. Sometimes when angle is different from one side to other side because of the atrophic facet or dystrophic facet, in those cases, it goes for a scoliosis, deformity. So we have done that study, and then it is mainly because of the orientation of the facet angle that have a very good relation and a very impact factor on degenerative listhesis, which I got a slide which I will come back to you.
Yes, sir. One basic question is asked, one delegate is asked, why L4, L5 is most common in what?
I think what you yourself can answer. I leave it to you. Nalli, I'll take him to water. Yes, Nalli, you can answer.
Yes, sir. See, like this is to something to do with the biomechanics of the spine. See, normally we see the degeneration in segment where the highly mobile segment becomes static, the less mobile segment. Like for example, if it's going to be the thoracic and the lumbar and the sacrum. So this is the region where there is a transition from a more mobile to a lesser mobile segment, and that is the reason why there's a lot of stresses which are going to concentrate in this region, and that leading on to the degeneration. One more thing, the second one, what I've seen is a lot of biomechanical alterations are seen in this region. Like for example, there may be as Sir said, there may be a change in the orientation of the facet joints, or a lot of anatomical abnormalities also have been seen in this region. In my observation, we see a lot of anatomical observations. Like for example, it can be a facetal orientation, or there may be a transition vertebrae with one side there may be the larger posterior anatomical structures leading on to various biomechanical alterations. So these biomechanical factors lead to the incidence being more in the L4-5 segments.
Yes, can I add one more just for the postgraduate point of view? That is the normal, if you remember the embryological position, it is a universal flexion attitude. It is C. See, there are junctional, the cervical and the lumbar, they develop. When the child starts looking up, the cervical lordosis develops. And then when the child starts walking, this lumbar lordosis develops. The thoracic and sacral universal C, the kyphosis maintains. If you see the symptoms, if you go back retrograde and see, you have got a 7 cervical, only 5, 6, 7 get a disc. If you got a lumbar, 1, 2, 3, we commonly get L4, L5, because whatever we get a change, these two changes are occurred in the spine because we attained erect posture. Whenever you go against the nature, you'll have a problem. That's why you get a varicose vein, you get varicose veins. So the universal curvature of the C gets changed in those two places. That's why the mobility is more, and then the problems are more in that area, lower cervical and lower lumbar. This is just for postgraduates.
Dr. Bharani, do you have any questions?
Yes. I have a couple of questions from the delegate side. One interesting question is, what is the role of epidemiology in stenosis? Like hard water, does it predispose to stenosis?
Bharani, you can.
Yes, sir. Probably they are hinting about fluorosis causing stenosis.
Yeah.
Fluorosis definitely leads to calcification, ossification of ligamentum flavum, posterior longitudinal ligaments. All these can narrow down the central as well as lateral rhesus. So they technically can lead to stenosis. And the other extension of this, one more delegate, smart enough, has asked, what type of stenosis does it cause? Is it a static or a dynamic stenosis? What type of stenosis it leads to? Fluorosis.
Fluorosis. Naturally, it is there in the deposit there only in the soft tissues mainly. Either it is there in the ligamentum flavum or longitudinal ligaments, or anteriorly you go for ALL or so. This is majority of the involvement in the dynamic portion, not on the static usually. When it is so gross, extending proximally and distally, it can occupy the static area. But as such, static part of the borders do not get affected. The area may be occupied when there is a severity. That's all.
But as the ligament...
I think once again, it's the dynamic component is affected in fluorosis also. Yeah.
Yes. All right. And one more question. Any early predictors?
I'm happy that boy has listened to my lecture at least. That's why he has asked this question. Yeah.
One more question is about early predictors or risk signs for stenosis. Are there any early predictors which will tell that somebody will develop stenosis?
No. We can't say that because, the listhesis you can predict, degenerative listhesis we can predict. And we can't say, suppose it's something like somebody asks you a question, sir, we can predict how this fellow will get a gray hair, this fellow. It is something like the same degeneration which is seen outside, which is seen inside. We can't predict. That's why I told you, sometimes we get a very gross changes, but patient is comfortable.
Yes.
So we can't predict.
All right, sir. That's all we have for
Yes,
this
sir.
session. I think we
Yes.
can go ahead.
Okay, shall I start the second
Yes, sir.
one?
We can go ahead with the second stage. Sir. Yes.
Yeah. I think if not the other consultants, I think postgraduates must see part as very important, because you will get a case clinically examined. Disc prolapse is not there, trauma is not there. They will keep a case of lumbar canal stenosis, and then you have to, then they'll ask you, sir, many a times I have seen in the exams that why you say they come out to the diagnosis of lumbar canal stenosis, but many a times when we say that why do you say lumbar canal stenosis, they are not able to explain. So I think postgraduate must listen to this part very well. You must, it will be very useful to you. Now, how to approach lumbar canal stenosis, a clinical approach. You have to make a clinical evaluation to diagnose, and a radiological evaluation to confirm the diagnosis. And the laboratory diagnosis has to be done, evaluation has to be done to rule out any differential diagnosis if any, and you have to plan the treatment. These are all the clinical approach ones you should have. Why I say the clinical evaluation to diagnose and the radiological evaluation to confirm? Because many a times I have seen the postgraduate, as and when they see the case, they ask for an MRI, not for spine only. When you say the case of knee joint and osteoarthritis pain, they immediately ask for an X-ray, because they ask if they are going to treat the X-ray or MRI. So a clinical evaluation has a first priority, and a radiological evaluation only to confirm what you made a diagnosis. This is very important. Now, it is not in the lumbar canal stenosis examination in no way, clinical evaluation in no way different from any other examination, something like in orthopedics. But whatever it is, you should have a systemic and sequential approach. There is no alteration in any of this approach. That is something like inspection, palpation. This is the order. If you miss the order, probably you will miss the bus somewhere. So never change, whether it is a spine examination or a orthopedic examination. These are all the standard system protocol which you go systematically and then sequentially one by one. If you remember this word, have anybody can remember this word somewhere? Tongue first, eyes next, and hands last. It is given in the clinical method of DAS. I don't know how many of you have seen this. As and when you see the first page of this book, Clinical Method of DAS, they mention tongue first, eyes next, and hands last. That means you have to talk first, and then you use your eyes, that is inspection, and then hands last. You have to put your hand on the patient. Because I've seen many times a postgraduate, somebody will questioning and somebody will just come and put palpate or do a reformative position, or they're trying to demonstrate some signs or not. So that should not be the way in which it has to be tested. Talk to the patient, see, and then finally you palpate. So what to talk? History. That is a very important. History taking is an art, giving insight to the patient, and it provides a direction for your examination in what way you are going to do. Because in many times when you present the case, when you state the history, the examiners will intervene. Come on, Baba, what is your diagnosis? The boy will wonder, because why I am not only the history, but the examiner is asking the diagnosis. It is not the diagnosis, exact diagnosis is expected. At least by the time you complete your history, you must be able to say whether it is congenital or traumatic or infectory or inflammatory or metabolic or a tumor or something like this. You can choose any one of these 6 or 5. This is good for either in spine or any other examination. After all, the patient is going to have one of these diagnoses. Of course, subdivision. The more and more you are going to progress for examination, inspection, palpation, you can go on, choose among the infection means you can choose among various sub-headings. So by the time you complete your history, you must be choose and then direct your examination according to that. And based on that, determine the laboratory and imaging modalities. For example, if I am going to think of some infection, probably I give a TCDC and ESR as my first priority. If it is going to be degenerative condition, whenever I'm going to think of a laboratory investigation, I'm not going to think of a ESR first. So that is the way you have to determine. Same way imaging modalities, whether to order for an X-ray, MRI or CT first. X-ray is the basic, of course, which I'll talk subsequently, but whether to prefer an MRI or CT, you can't take both. Patient is not offered to take both. If you are having your own MRI, it's well and good, you can take it, but not for the patient. So your history will determine what laboratory findings or imaging modalities you choose. And then the plan of treatment is very, very important. After all, it is the patient's physiological demand. You cannot find out by examination what the patient is occupation, what he needs, what is his physiological age. Physiological his retirement age is 58, but it is not, you don't put down your knife at 58. The same way every profession is having their own age. So what is the demand of the patient and patient willingness, patient general condition, comorbidity, all these things you can bring out by history taking. History taking is very, very important in lumbar canal stenosis because you've got the more symptoms than the signs. It is a clinical challenge to make a diagnosis of a lumbar canal stenosis because a lot of plethora of symptoms, umpteen number of symptoms are there, but there are positive signs. Signs will not be there much like any other disease. Patient will complain of so many symptoms that commonly you present with the back pain, leg pain, and then the claudication pain. And then a combination sometimes, the claudication and the leg, claudication and back. And so this combination can occur. This will be chronic pain. And the next complaints will be patient will have a leg pain, weakness, numbness, heaviness, tiredness, and claudication. You see, can anyone find out of these things by examination of inspection, palpation, etc., etc.? No. Numbness, either you say the examiner will ask whether there is any sensory loss is there or not. Don't say numbness. Heaviness, can you examine them, then can you weigh the limb and then say tiredness? No. Claudication, once again, which I come to the later, how to define a claudication. And then these are all the things which can be made out only by the history taking and not by examination. So, because it is more of the symptoms disease than a science, positive signs. So it is a very challenge clinically. When sometimes when the patient says, so the candidate says, sir, the diagnosis is lumbar canal stenosis. Doctor, why do you say it is lumbar canal stenosis? They are not able to say there is a blank because they would have got a clue, or sometimes there may not be any findings at all, only symptoms. And then so they are very blank when you ask why you say lumbar canal stenosis. So majority of the lumbar canal stenosis are based on the history taking is very, very important. You can have a chronic back pain. For example, patient says a chronic back pain. By history, you can rule out other causes. The back pain can be varying the site because, for example, upper back pain, you can have like a renal related or abdominal related, liver problems. Lower back may be prostate gland, or commonly you'll have gynecology. So all these things, because as a spine surgeon or orthopedic surgeon, you are not going to a PV or PR because it is a standard answer by the candidate to the examiner. Sir, I asked for the glove and then the glove is not available. But you can ask, nobody prevents you asking. Patient is not having a gynecological problem or a renal problem. And that will rule out. That is where the history you can't examine. So a chronic back pain, other causes can be ruled out by the history. And the leg pain, once again, it is due to the disc or a stenosis, you can ask by history. The nature of the pain, continuous pain, or there is a waxing and waning. There is a pain interval between the spells, that is a disc. And the stenosis is almost mechanical, continuous mechanical problem. So it is going to be progressive pain. So these are all the things can be asked by the history itself. You can't do examination then to find out. Coming to the claudication once again, a neural claudication or vascular claudication, we can very well differentiate by the history. After all, what are the points, the difference between a neurogenic claudication and vascular claudication? I have tabulated in the subsequent slides, but in that slide, I'll tell you how many findings are there for the differentiate between the vascular claudications. So all these things can be differentiated. And next one important is sphincter and sexual function. We are not going to examine the sphincter, whether bladder is incontinent bladder or a spastic bladder or upper motor neuron bladder, dribbling. All these things, you are not going to do a systemetry or anything else. You are going to ask the patient the initiating problem or dropping a problem, or it comes in a quantity and then stops, and how sexually related. All these things, mainly you can bring out history. No positive signs are there. Above all, when you examine the case for neurological evaluation, sometimes you may have a normal neurology. Patient will be absolutely no neurological deficit. So what all the history to differentiate all these findings, but history-wise, you have to tell me, based on this, I made a diagnosis of the lumbar canal stenosis. So you have to substantiate with your diagnosis with the majority of the case, unless you know how to differentiate between all these things in the history. Now, pain, just relevant to the spinal canal stenosis. I am not going to give the entire spectrum of pain because it is already covered by the physical examination of spine by Nalli, and then subsequent lectures on tuberculosis, on disc prolapse, I have told you. So, with the site and the axial pain, radicular pain, claudication pain. So, these are all the common presentation in lumbar canal stenosis, either one or two, very rarely only one. For example, disc prolapse, they will have a radicular pain predominantly. For a lumbar canal stenosis, you have predominantly at least two of this one, axial, radicular, or claudication. Probably claudication is the cardiac canal involvement, radicular pain may be due to the root compression, and axial may be a listhesis or something like that. So any two symptoms will be there. And the onset, it is going to be insidious and slow progression, and severity and character of the pain, as I told you. A nerve root compression is a chronic problem, a persistent problem, persistent compression, persistent inflammatory changes. Whereas disc prolapse, it varies because the size of the disc varies, something like because of the edematous changes. But here it is a continuous. So it is continuous pain, static pain, excruciating pain from the disc, and then associated with the only paraspinal spasm. Not right-sided scoliosis, but the disc or paraspinal spasm, very prominent list, something like that may not be there. And then the duration, diurnal variation, all these things you have to ask with the history. And this is very important. What are all the factors which release? As I told you, if you remember the dynamic stenosis, that is canal gets narrowed on extension and it is more widened in flexion. So the patient will be more painful when they extend the spine. And the example, if you ask for a patient whether you are climbing up downhill, uphill, he said we are not going to climb the hill. But you can ask whether you can climbing up the stairs or climbing down the stairs. Probably climbing down will be more painful because the patient will balance right to extend more painful. So climbing up will be easy. So these are all the things which you can take it from the history, and this will be positive. Now this slide shows you the difference between how a neurogenic or vascular claudication is there. I have almost given 10 columns. You see the pain, back pain, palliative factors, provocative factors, uphill pain, and walking distance. All these things only by history examination. Uphill, you can ask the patient. All these things can be, of all these things, next to other last four things, trophic changes you can see your inspection. Skin you can see, inspection comes into play. Motor weakness, when you see the patient, it may not be there. What patient will be absolutely normal. Only positive finding to say it is a neurogenic or vascular claudication is a distal pulse. All other findings, majority of the findings which is enumerated in the tabular column, you can confirm it by the history rather than putting your hand. Only one, the distal pulse. Majority of the time, the patient say lumbar canal stenosis, and the candidate is asked whether you palpated, because we deliberately ask whether the fellow thought of about vascular claudication. Majority of the time, they say no. So in the given case, a lumbar canal stenosis, you are supposed to complete the examination and with the distal pulse, dorsalis pedis or radial artery or whatever, upper limb or lower limb, you have to go for tibialis posterior tibial artery and the dorsalis pedis. So that will be present. That is only palpable signs present. Other three findings are inspected. That's why I said history taking is a very, very important. Even you can delineate whether it is a neurogenic or claudication. Now, neurological examination, most of the time, this is in a nutshell, I will give you, you have to do a complete thorough neurological examination, even though we say there may not be any findings. But usually when you express the neurological examination, we always say it is proximal muscles. We always talk about groups. Either we say it is whether flexors or extensor, abductors or adductors. We say in groups, we don't care about this gluteus maximus or medius. Specifically, we don't ask. Then distal muscles, we ask individually. For example, whether EHL or FHL or tibialis anterior, because each one has got a separate root, whereas all the other group muscles has got more than one root. So it may not be of much help unless it is very grossly involved more than one root. That's what I told you. In the disc, it is only one root for practical purpose. So distal muscles, especially you have to examine the individual muscles, and proximally group and dermatome-wise also. Usually it is normal, as I told you earlier, neurological examination in lumbar canal stenosis, unless it is very chronic, when there is more than long duration, you may have a finding. But one thing we should not forget, because when the time you see present the case, it will be normal. And the examiner will be sitting on the main table. He will ask the patient to come back to him. And then he will ask him to sit in the chair and then see, come on, lift the head, there will be weakness will be there. But you will be surprised. When I examined it, was normal. The trick is, the examiner is sitting in this chair and then asking the patient walk and then see the motor power, which you do not done it. You do done it, the patient lying down or standing, that's all. That is not going to produce any neurological deficit. So one thing you should important is, you examine the patient, while writing the case sheet, ask the patient to have some stress, either walking nearby or try to climb up there. Once again, you re-examine the patient for motor. You may have a finding. So this is very, very important. Re-examination of stress is very important. Otherwise, majority of the cases, invariably it will be normal. And evaluation is the key to a successful outcome, I told you. Because not only you clinically examine, taking a history, it should be correlated subsequently with your radiological evaluation. Normally in those days, we had an X-ray and myelogram in 1980s when I was doing a postgraduate. So majority of the time, the list you say, laparotomy and proceed, arthrotomy and proceed, not much of an investigation in all the fields, including the spine. So we have opened, many times I have seen, case was opened for a disc, but surprisingly, we have seen a neurofibroma inside. Because not in radiological advancement was not there at that time. We had only an X-ray, a poor X-ray, and then with the myelogram. But subsequently, we had got advancement in the radiology, a myelogram, and then the CT. So all these things, which one to use? All the three, as I told you earlier, you take all the three for a patient may not be offered to take it, and moreover, in radiology, exposure and all is there. So all the not as you like, it is what the condition, clinically guided radiological investigation is necessary. But going for an X-ray, it is very important. But majority of the times, boys write straight away an MRI. Or sometimes even patients straight away go to take an MRI and they come with an MRI with the consultation of the consultation room with the MRI. And then when I ask back, do you take an X-ray? Whether you have taken an X-ray? No, sir, I have not taken an X-ray. They think they spend more in the MRI and they can find out. No, it is not true. X-ray is the basic for any part, and particularly in the spine, it has got a very, very important role. So do not skip the X-ray. It is a basic investigation. Whether you take MRI or CT, immaterial, but X-ray is the basic investigation. And never give opinion or never come to a conclusion with one view. Always take APN and lateral. If necessary, special views, something like a APN lateral in standing or dynamic films if necessary. And the proper coverage and exposure is very, very important. Because the whole lumbar spine, suppose it be exposed from L1 small plate, and then the radiotechnician decides that you specifically ask for the whole spine from D12 or L1. For example, the commonest complications in any spine surgery is wrong level. You see in this patient, you see that there is an accessory rib. Suppose the patient have a cut here, I would have taken as a D12 and L1, L2, L3, L4. I would have made a conclusion it is a sacralization of L5. Sometimes I go for above, I'll take L5 from down, I'll take this as a D12. That's why wrong level surgery happens that one. You cannot make it much in an MRI and in the CT. This is the best one, basic investigation in X-ray, which you can count and see the findings are there. Then another one thing I told you, in those days, we had a very poor X-ray. Sir, X-ray that much it has come. Because the plant will be 100 MA or 50 MA, which is good for the limbs, but not good for the spine. The X-ray is very, very important. A lot of things to be seen in X-ray. The importance of the X-ray is, one, a proper level. And number two, the interlaminar window. You see, this is what you see, the shadow. You see the interlaminar window. And then this interlaminar window varies from, as I told you, the canal varies from size and shape. The window also varies in size and shape individually from 1 to 5. You see, if you follow this L1, L2, L3, L4, L5, the interlaminar window is different. Nowadays, most of the surgeries, majority of the surgery is going to be interlaminar window based. And sometimes the surgeries will be based on transforaminal base. So to assess the entry, the door, when you want to enter into a room, the door is very important. That's how the interlaminar window you can assess. This window size you cannot assess by MRI or a CT. So it is necessary to see a good X-ray with adequate exposure and good coverage, and try to have some time to switch to see the interlaminar window. Next is what this film AP and lateral you are seeing here, you are going to see on the table with the CM. You are not going to see the images what you see in the MRI or CT. What you see in an X-ray is going to be there in the CM film. So this part there you see the, I told you that is the narrow disc or L5 or S1 or something like that. The majority of the confusion will come when you operate on the table, because you have concentrated more on an X-ray unless you see this area, which one is the square vertebra of the L5 sometimes. Normally the L5 is a trapezoidal, it is not a square. But in the semi-sacralization, there is a separate category is there, classification is there, but it gives you a practical problem on the table, which cannot be shown mainly by the, unless you take a 3D CT, you will not be able to see that. But this one, you can see it in the plain X-ray. That's why I said orientation with the C-arm is very, very important if you orient with an X-ray. Then next one, when you see a spur like this, you can anticipate a deformity. You see the spur is not going to be on the both sides. It is more prominent on one side, because these cases can go in for a degenerative scoliosis than the other cases. This will have a very good impact when you are going to plan for a fixation on this level. Subsequently, patient will come back with the deformity proximally. So looking at this spur, how it is, where it is symmetrical on both sides, this will be MR. Then next, sometimes it will be used to rule out a differential diagnosis. When you see a spur localized extra bone formation here, probably you'll be having a case of a dish, which you can start screening the spine. That can produce the lumbar canal stenosis. And sometimes when you see in the posterior fascial joints may not be seen like this, which can be due to rheumatoid or ankylosing spondylitis or fluorosis, something like this, which will rule out the differential diagnosis. X-ray only be a clue, that's an increased density, look for other things. Here also, once again, a classical example. In this case, it is a square vertebra, there is a disc space, linear disc space is there. If this picture, unless you see in an X-ray, you straight away go and see in a C-arm, probably you will have a trouble which one is L5 or S1. That's why orient your eyes or develop the habit of the eyes to see the image here and then see the X-ray. Then I told the as and when you see a spur in different lines going on in this area, so probably warrants a dynamic extension and flexion, which will show you a subtle distances. A subsequently patient may develop. When you say spur in different, particularly in one segment, probably some instability is there at that side. Be very cautious. Now coming to an MRI, it is the gold standard for the lumbar canal stenosis is concerned, because it can identify a pain generator and it alters your surgical plan. And this is a basic axial cut. If you carefully see whether the patient is started developing, for example, this is normal. you see the concentrate on this spinal canal and then this cardiac fibers. You see this is all the cardiac fibers are sedimented on posteriorly because you are taking an MRI on the supine position. But whereas if you see here, this sedimentation is not there. It once again confirms this is going to be a stenosis. Of course, other findings you confirm. But this is very important to make a diagnosis. The earliest sign of a lumbar canal stenosis in a given case, that is called a sedimentation sign. And then we use this to grade the lumbar canal stenosis. That is mainly depending on the CSF and the root plate ratio. For example, grade A, there is a stenosis is there, facet changes are there, but it is almost equal. Here you see the proportion of the root plates and then the spinal fluid level. You see here, you see the grade 3. You see absolutely grade D. I'm sorry, it is written the wrongly typed as C. It is D in fact. You see absolutely no CSF. The more the severe the grade, probably more you have to be very cautious and then don't give assurance to the patient. The patient will get back. Probably patient will get back with the pain, but numbness may not improve. You have to be safe because preoperatively, if you tell the patient after assessing the MRI, probably you are safe. Otherwise, you are likely to be in trouble. You are going to get a nagging from the patient subsequently. So MRI, you can find out all these things, and MRI is the choice, first choice. Apart from that, you can exactly localize where it is. You see here, the front disc and then the ligamentum flavum. You see once again, no sedimentation here. You see the foramen is empty. You see this is the normal foramen. See, nerve root is there. Whenever you see an MRI, don't contend with the sagittal view. You yourself read. I feel every surgeon who is going to put a knife on any patient, including general orthopedics, and especially spine surgeon, he should read an MRI. Because as I told you, if I take an MRI for me or any one of the faculty sitting here, the radiology will say there are a humpty number of reports will be given. But all the reports are disc degenerated, C5 narrowing is there, an osteopathy is there, this and that. Humpty number of finding is there. Whether that is symptomatic. That's very, very important. That's why see because you are seeing the patient, the radiologist, you have got a luxury enough to see the patient, whereas the radiologists do not have that luxury. They will say simply stenosis is there, this and that. A good radiologist will really lead you. But majority of the time, somebody gives a cut, somebody gives a diagnosis, and you are depending on that, you'll be in trouble, or you cannot give a successful surgery or successful treatment for the patient. So you try to see the foramen, you see the changes here. This is the nerve root foramen, nerve root is here. The other periphery is the fatty tissue there around or water content. And you see here, the foramen is, nerve root is missing, it is pushed to one side. And the sagittal MRI, if necessary, depending on how much of osteophytes you want to find out, you specifically ask for the cuts. And this is for just for description purpose. I have point. This is the cardiac canal. This is sympaticular zone, foraminal zone, and the extraforaminal zone. You see the foramen once again is missing. So what the mind, what the brain do not know, the eyes cannot see. Unless you know what are all the sites of obstruction, sites of pathology is there, pathological anatomy is there, your eyes will not see that. So that's why I started with the pathogenesis and pathoanatomy. This much of detail, the radiologists do not have. Whereas you are having the opportunity to see the patient, make use of that, correlate along with the symptoms. Not every findings in the spine I cannot operate. So if some of the faculties are also subjected to spine, we have to C1 to COX-4, we have to operate. We'll have symptoms, we have the radiological signs, but it is not so. For example, this is the osteophytes, which we have seen that, and this is a facet joint, the opacity is same. This is a cyst impact occupying the canal producing symptoms. And so this is just once again to stress upon various processes of the subarticular stenosis, and the foraminal stenosis here, and the foraminal stenosis due to the disc there, and extraforaminal disease mainly due to the cyst from the joint. They happen to be, see this I operated with the patient, this was the cyst, nothing else. So these are all just to know, predominantly radicular symptoms, these types of lesion is there. You see, the canal is almost normal. Canal is almost normal here, but for here. So these are all some of the cases where they can produce only radiological radicular symptoms may be associated with early symptoms of this. All the glitters are not gold. So all the radicular symptoms are not only due to the disc. There are other causes of the stenosis may be there. You should not miss. Then you should something know about axial loaded MRI. That is adding a weight to the patient and then they take an MR. You see, this is the difference. What you see, the canal here, when you put on weight, it gets narrow. Usually they don't do it now unless you ask for it. It is not a new one. It has come into practice in 2009. And the majority of them, because radiologists don't take this because it takes more time. But now you have got a dynamic MR. Dynamic MR has come. You need to have a separate software to analyze. And majority of them, because of the paucity of the time, radiologists don't practice and you don't ask for that. But it is coming to practice now, dynamic MRI. Then coming to the CT, when to take a CT, when the MRI is the gold standard, whether CT is necessary? Yes, it is necessary on these occasions. When there is a bony element, not due to the static causes, but it is due to the changes in that a bony spur like this, the body. Sometimes it can be in the center or it can be in the foramen. Or when there is a foraminal stenosis, or when there is a subarticular stenosis. Or this is another example to show a you can see the compare on both sides. This is the lateral canal subarticular area. The subarticular area is compressed because of the osteophytes. So when you feel that there is a bony cause, better CT only can demonstrate. Because when we talk about indication, we say demonstrable mechanical compression. So when you feel there is a demonstrable bony changes are there, at those days, better to take a CT. At those occasions, only CT is warranted. Otherwise, when the MRI cannot be done in a situation like a pacemaker is there, or the patient is having claustrophobia, allergic to noise, or when there is an implant, which will have a overshadowing or pseudo illusions will be there where that area because of the metal. If you have a titanium, previous surgeon has used titanium, probably you'll be able to see something. If it is going to be stainless steel, you are going to be out, MRI is not going to be useful. At that time, probably you can use CT and then the contrast CT will throw a light. And one more, when you are going to do a revision surgery, what the surgeon has done previously, the bony work, when you are going to in, because the bony, the rest behind, the left behind bony mark by the previous surgeon is going to be lead you. That is going to be an island of island in the ocean of sea. So unless you know that, you cannot be confidently going to the service. So only on these three occasions, MRI may be warranted. One is a bony cause of the compression, and MRI cannot be taken for situations, or when you are going to do a revision surgery where you want to get some clue of the bony work of the previous surgery. Otherwise, MRI usually we don't take. Now coming to the serological investigation, it is mainly to rule out other diagnoses for something like with the old discussion we had, pages can produce stenosis, fluorosis can produce a stenosis, disc can produce a stenosis, ankylosing spondylitis, rheumatoid, all these things. So on those occasions only you need to have serological investigations. Then coming to the electrophysiological, is there a role for electrophysiological investigation? Yes. Because in the aging spine, the burning pain, and then the numbness, to rule out other comorbid like peripheral neuritis. When there is a disproportionate pain, do not correlate with the radiology to rule out a peripheral neuropathy due to other causes. You can take electromyography or non-conduction study to rule out a peripheral neuropathy. Is there any role for this reflex? Yes. Only but applicable to only yes nerve root, just one nerve root. Otherwise, it may not be useful. So you have a role of electrophysiology also in demanded conditions like peripheral neuropathy. Otherwise, it is not of much of use. I think I'll stop here. I'll give a break. Okay?
Yes, sir.
Till now, we have not had any questions from the delegates, but I would like to add a few points there.
Yeah, you can. That's why I think they have put you as a moderator.
Yes, sir.
as an experienced surgeon. Yes.
Yes, sir. So I think you nicely put it like there's a plethora of symptoms and paucity of signs.
Yeah.
And in your talk on the neurology examination, you said that the motor weakness may not be revealed obviously in some patients.
Yeah.
So I think this was one finding which was very commonly stressed by my teachers during my PG period. Like sometimes the patient might come with just symptoms of claudicatory pain only without even back pain.
Yeah.
And on examination, we may not find any motor weakness at all.
Yeah, yeah.
In such situations, I think it's very important. I think you nicely put it. So I just want to stress upon this point that re-examine after stressing the patient.
Yeah.
Like the stressing, like it could be like asking the patient to walk for a short, you can make him walk, or you can also make him sit and stand at the same spot. You can repeatedly ask him to sit and stand like repeatedly. And then once he develops the claudicatory pain, then if you examine, they will come out with motor findings. You can find the neurological findings there. And second one was the, I want to just add that sphincter symptoms, like the presence of urgency or hesitancy, may also be a feature of spinal stenosis. So the question with you is like the presence of claudicatory pain, does it vary between the patients with those who have a central stenosis from that of patients having lateral stenosis? Does it vary?
The claudication pain is majority due to the central, and
Yes.
the lateral stenosis they manifest as radicular pain.
Yes, sir.
So it is there is a majority of the. That's why you also mentioned claudication is common.
Yes,
Whether a patient is have a radicular pain, probably you think of lateral. Whether it is the back pain, probably some instability or deformity, something like is going on with the joints. So claudication pain will be there always. It may be plus or minus with the radicular or back pain.
Yes, sir. Now, can we say that a central stenosis will present with symptoms in both the lower limbs, claudicatory pain, whereas if it's going to be a lateral stenosis only, like it will present in only one limb, sir? Can we say that way?
Yeah, radicular. Yeah. You can.
Yes.
You can.
The claudicatory pain will present in one limb only if it's going to be.
Yeah.
Yes, sir. Yes.
That's what I told you once again. They should know the radicular pain will come to the tip.
Yes.
Whereas this one will not come to the tip of the toe. Probably it will start with the calf and then go ahead.
Yes.
Or ankle will go ahead.
Yes. Okay, sir. I think that's it, sir. Now, Bharani?
Bharani
Yes,
is
sir.
there?
I have few things to add, sir.
Happy.
PG's point of view, as an examiner, what all would you expect from a postgraduate in gait assessment? We all know gait assessment is important for lower limb examination.
Yeah.
For spinal problems, what do you expect as an examiner from the PG student?
Nalli, the current examiner, I am a depend B.
Yes, sir.
So I have few in mind. You can add on.
Yeah.
First thing is, it's one objective way of assessing the claudication distance what the patient complains of. Another one is immediate neurological or vascular assessment can be done once the patient develops symptoms. And that is one way of looking for special gait patterns like foot drop gait or Trendelenburg gait. All these will give a clue about the anatomical location of the stenosis.
Yes.
These three things I will definitely look for.
Yeah.
Apart from this, anything else, sir?
So one more thing I would like to add is I think we should rule out a tandem stenosis.
Yeah.
We need to have a whole spine MRI.
Yeah.
I think, yes.
I thought I'll put it subsequently. Okay, you mentioned it. Yes. Complete. Having mentioned, you just tell for the postgraduate point of view. Having mentioned,
Yes, sir,
you
I
can
think
elaborate what is stand-up.
Yes, sir. I think we can have another, like it's in a degenerate spine, there can be a stenosis at another level, one level. It can be any level. It can be thoracic or it can be most very commonly it is the cervical spine. So hence we should have look the entire spine. We evaluate with the whole spine MRI, and then we should rule out a tandem stenosis. I think this has to be kept in mind.
Yeah. And one thing is, can I add one more, Nalli?
Yes, sir.
And the tandem stenosis is, as I told you earlier, the degenerative changes more in cervical and lumbar. Otherwise, in those days, it was called as a cervical lumbar syndrome.
Yes, sir.
And now having established that in the MRI, we say it is tandem stenosis, number one. And number two, clinically, when you examine the case properly, you will get tandem stenosis. Even though patient may not complain of a neck pain, patient may complain of claudication pain. When there is symptoms due to the cervical also, patient will invariably develop an upper motor neuron signs. There is an exaggerated reflex, and at that time, because it is a lumbar is there, there is not a hypo. It is a lower motor neuron lesion. So you may not have a clear-cut picture of a lower motor neuron lesion. You may have a upper motor neuron signs also. So if you that's what the important of a clinical examination. Even though there may not be any symptoms, if you routine examination, if you go by sequential manner, examine the patient clinically, neurologically. If you find out any spasticity or any exaggerated reflex, you ask for that. So clinical examination properly done, you may not miss the tandem stenosis, number one. And then regarding gait pattern, adding up to the what Bharani told, in a cursory examination to see in the op-day whether patient is, ask the patient to see if the patient is going to have a bilateral paddling gait, probably gluteus medius is weak, because we have kept as a spine case, need not be always Chandramberg side positive, something like that. When you make the patient walk, you can observe the patient has been bilaterally striding or unilaterally bending, it is going to be a muscle weakness. And then next, commonly for a random examination for the post, I don't do it routinely, but otherwise you would at a time at least do this test. One, you walk on the toes or walk on the heel. Probably the patient is having a dorsiflexor weakness, we may not be walk on the heel. If you have a quadriceps weakness, triceps weakness or gastrocnemius weakness, patient may not be able to walk on the tiptoe walking. So apart from the foot drop gait and this one also can be added up.
Yes, sir. And one another point is in the clinical examination, we should also do a good hip examination also. Most often, a lot of times the hip pathologies are masked by degenerative changes in the spine also, sir. I think that has to be.
Why a hip?
Yes, sir.
They'll say and then they'll be missed. Yes.
Yes. And Thanapan has put forth one question, sir. How to differentiate the sensitive symptoms due to canal stenosis from diabetic polyneuropathy? Those who present with vague radiating numbness in the legs, not typical of claudication. Yeah,
of course. As I told you, both will not have any signs. Yes. If you suspect that, better take an MRI. The pain, the gravity of the pain do not match with the radiological symptoms. And the patient is a known case of diabetes, better think of peripheral neuritis, uncontrolled diabetes, prolonged diabetes, severe pain, but radiologically that not much of a radiological signs. You have to think of a peripheral neuritis.
Yes. Yes, I think that's the reason why we should keep the peripheral neuritis as one of the DDs for spinal stenosis. But you should have the, as you said, sir, a good clinical radiological correlation.
Yes, sir.
Yes.
Always.
Yes, I think we can go to treatment, sir.
Yeah. I think.
So we have one more question, sir.
Yeah.
One more question about lobster claw sign in stenosis in radiology. Someone wants to know about that.
Yes, Nalli.
No idea, sir. That's the reason I skipped it.
I think I've heard about it. It's a more cervical cord injury related radiological MRI sign. It's a cervical stenosis, central cord syndrome related MRI sign. More of cervical related.
I think Arjun is reading too much. I think probably.
I think no. Just 2 points I would like to tell on this. One reason I was comparing myself to lumbar, I didn't touch upon that. That is one in general. Apart from that, I have seen there are certain postgraduates are there. Nowadays, they always have an access to the internet and cell phone. So they will test the teachers sometimes. The teachers must be very careful. They see something in that and then they ask, sir, what is this, sir? As if they do not know. So that type of candidates are there. Probably Arjun may not be like that. But as you rightly said, it is there in the injury, which I deliberately missed because it is not the purview of the topic today. Okay?
Yes,
sir. Can I stop you for one more thing? Point about straight leg raising test. Most often postgraduates will be confused about reporting positivity of SLR. So when do they call it positive? When is it negative? And then in stenotic conditions, they all know it is a radiating pain. So they believe it has to be reported as positive. They'll write it as 60 degree, 70 degree positive. So is it relevant?
No, that is an SLRT positive. Once again, I didn't touch much upon that because it is mostly confined with this. But anyway, having raised the question, we are to see the SLR will be, you can take it into positive once it is crossing that is 35 to 70. Beyond that, usually beyond 70, where the patient is generally is not going to do it because their hamstrings will be tight, even including many of us, because we don't stretch the hamstrings always. So the positivity can be taken majority between beyond 40 and 70. Otherwise, in 30 degrees, probably you have some other reason to develop.
Okay.
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 Shall I go to the next topic?
Yes,
I think we are getting more time there. Shall we finish or Kirkaldy? Go ahead.
We'll get finished off because time is also running.
Okay. And now this part is, I think everybody, even the PhD postgraduate and mainly consultant has to listen, and I'll go in a very quick manner. I think those who you get got for a tea or slept, please wake up and then listen to this area because it will be more useful bread and butter today. But basically, coming to the treatment, there are two treatments, non-surgical and surgical treatment anyway in both. And surgical, non-surgical treatment should be the first line of treatment, and then even surgery indicated but could not be done for so many reasons. So we have to carry on with the non-surgical treatment. And the patient not willing for surgery, you have to adopt only non-surgical treatment. We have got no other go. So in these situations, non-surgical treatment you have to do. And then the pharmacotherapy. Number one, NSAID, pregabalin, B12. There are so many things are there which is beyond the scope of this. And physiotherapy, there are exercise means somebody asks stabilizing exercise you are going to do, whether it is going to do promote or aggravate it. No. We have got these much of Williams flexion exercise, mechanism exercise, functional stabilizing exercise only for core muscles. Once again, I leave it to postgraduates to go and see, because if I am going to talk on this exercise, probably I missed the more important of a technical aspect of the surgery. So exercise means it is not a gross. There are so many various exercises are there. You have to fix the patient to the particular individual and then do that. Then septum diathermy and then these TENS, braces, they have got a role there. And then injection, facet joint induction, probably at the earlier stages when it is going for a facial arthritis. Epidural will give a relief. A lot of controversy whether you give an epidural or not, but still there is a documentary evidence to say that the epidural definitely relieves the pain, but it gives a temporary relief, cannot be suitable for those patients who are not fit for surgery. And root block can be advocated in both ways, both diagnostic as well as temporary relief for the patient. And then overall, even if you do surgery, probably advise the patient to go for a lifestyle modification, that is adjustments. Don't do certain things beyond certain age group. You have to accept that, and then try to keep the spine flex, whatever way you do that. According to that, the lifestyle has to be modified. Special walkers are all available. So what finally, the lifestyle modification has to be done, avoiding extension which provocates the pain. Now, conservative treatment, surgical treatment indicated in patients with the failure of standard conservative procedures. They are not just like they're giving some analysis, some exercise and to do that. You have to analyze the patient, do what type of exercise you have to give it, and then if it fails, then you think of surgery. And surgery should not be taken as an emergency, unless and otherwise it is going to be a cardiac syndrome. Don't take it as a only elective procedure, something like a disc prolapse. Do not go in for emergency procedure. And then the surgery is mainly to improve the quality of life, avoiding the permanent neurological deficit. We cannot give a total cure because it is going to be continuous progressive disease. So if you do a degeneration, probably the patient is going to live for 20 years, another 20 years. Patient will come back to you after 10 years with the occurrence of pain again. So never give the assurance to the patient that you are going to give a permanent relief. You cannot do it. What you can do is improve the quality of life. So indications for surgery of treatment is failure of conservative treatment, persistent limitation of walking, and the neurological pain, severe pain, and then demonstrable mechanical compression. I told you repeatedly, stress, clinically correlated radiology, and then the cardiac once the bladder and bowel is involved, better do surgery. Now, before going for surgery, always localize. Unless you localize the pain generator, please do not operate. You will fail. Even if you operate on the table, you cannot search what is compressing, Tessergant syndrome. That is, you can, in those days, I do agree, you can open and see. But nowadays, the trend has changed. You can see and open. Make a clinical diagnosis, see what are all the pathologies, the advancing radiology is there. So unless you are locating the pain generator, please do not operate. So the commonest word which you have across is the surgery is the decompression surgery. That is common in any spine surgery. There are only two words, either decompression or stabilization infusion. Here, the hallmark surgery for lumbar canal stenosis is the decompression surgery. You have to ask yourself before deciding on decompression surgery, what to decompress, where to decompress, and how to decompress. The answer is freeing the nerve elements from compression, generally. You have to do a phlebectomy, you have to do a discectomy, you have to do a foraminectomy, and you have to do lateral release decompression. All the three things, but mainly based on clinically radiated images like this. Read the images, know the symptoms, correlate clinically which one is producing symptoms, and then locate the pain generator and then operate. Once again, the treatment varies depending upon one segment or multiple segments, whether it is central or lateral, whether it is associated with the instability, whether is there any deformity, and then the patient's factor. Patient not fit or diabetic, patient may not refuse, patient have a gross demand, of physiological demand, probably I will not do decompression, I may do a fusion also. So patient's factor is to be considered, and lastly, surgeon's expertise. What surgery you are going to do, you have to be very confident. Unless you are very confident, don't embark surgery because somebody else is doing that particular procedure. So it all depends on these factors. The decompression surgery, the technique varies according to all these factors. Now coming to conventional, there are two types of surgery. There is conventional surgery and recent surgery. Conventional means open surgery, and then the same open surgery when you magnify and do it is microscopic surgery. And then this is the commonest word nobody will be missing in these days. You are whether a joint replacement surgeon or a trauma surgeon, whatever is minimally invasive procedure is there. So you must be well versed with the minimally invasive spine surgery. And you have got options, the type of minimally invasive surgery, postgraduate should note down. You may not do now, probably you may do it in future when you become a spine surgeon. But right now you are supposed to know about all the recent advances. That's why I specifically put into it. I'm going to throw some more light on this, because it will maybe ask you in theory what is this in spine surgery or endoscopic surgery or short notes or something like this, or a tubular retractor. So these are all the various options: endoscopic surgery, tubular retractors, and full endoscopy, and biportal endoscopy. All these words you remember, go and read some more. I'll take a bits and beats here and there, but you are supposed to know all these things are recent advances to write your theoretical examination. Now coming back, the commonest surgery which we have done earlier is a gross laminectomy like this. The segmental level, unisegmental, we do like this, but a gross segmental level, we have done an extensive laminectomy like this. This was the very earliest 1960s, called a train tree laminectomy, in fact, which destabilized the spine, produced a paraspinal muscle scarring and bone morbidity. And then subsequently, when the CT-MR came, as a question was there, and Nalli pointed out whether it is unilateral or bilateral. Once again, the treatment varies. We can do hemilaminectomy when there is unilateral or multi-segmented unilateral. You can operate on only one side. But at the same time, when it is a bilateral and multi-segmental, we can have a laminotomy, not exposing the whole, excising the whole spinal lamina, which I pointed out in my pathological anatomy, that the problem or the disease or pathology is only the dynamic part. Why do you remove unnecessarily the static part, which is not the culprit? The culprit is the dynamic part. So remove the culprit part only, leaving the bony part intact. So we were wise enough, and subsequently we see and then open with an MRI or CT, rather than open and see earlier when we open with the myelogram only. Now we see before opening. So remove what is ought to be removed. So these are all the laminotomy, interlaminar. I told you, majority of the now going to be in future is going to be interlaminar space. So you have to know well versed about it. So this is an interlaminar, bilateral, multi-segmented can be done, less traumatic, and morbidity still persists. But it is multiple segment, including the bony problem, something like we discussed with the fluorosis or Paget's or something like this, where you need to do a bony absection also for some reason or other. probably you need a long multi-segmental stenosis, but of course with no instability only we can do this type of surgery. You can do the whole column can be open, once again without removing or disturbing the paraspinal muscles like this. You do a spinolaminar junctional osteotomy like this. I have presented a paper with a long series in the state and then the IYA meetings, and you see they do an osteotomy here, put a retractors on both sides, retractor, and do the job here, and then come out and close. There is one other way of doing this type of procedure. You split the spinous process like this with a burr, so that you don't damage the muscles, and then you fill it open, do whatever bony work you want to do, and then leave it and be close to the tip. So this can be done when there is a multi-level involvement with no instability, and then there is a part in the story 2 or story 3 bony obstruction is also there. For the same reasons earlier, you can adopt this surgery, which is less traumatizing than open surgery. Whereas if you are going to adopt the regular open decompression surgery, you have to extract the whole entire lamina of the lumbar spine. You see what the patient will come with the morbidity, persist with the back pain again and again. So this is one type of minimally invasive surgery where you have a multi-segmental stenosis with the bony causes also on these static borders. Now decompression, how much we do, we have to remove the lamina for regular conventional surgery. I mean, otherwise now I have done this, but now I don't do this. I think since last 15 years or 20 years back, I have not done laminectomy for, I have done laminectomy for other reasons, but not for lumbar canal stenosis. But I'm talking just for the conventional surgery for the postgraduate sake. You should not miss this. And the ligament of flavum has also to be removed. This is the normal decompression surgery to be done. And these two things, sometimes for a facetectomy, you do remove the facets on both sides. And sometimes you may have to remove the one facet completely. You go on, remove the bony causes, and at the end you see only one facet totally removed, or sparse intraarticular is damaged. So when you do the conventional open surgery, always see the pars is intact and the patient is adequate enough to maintain the stability. If you are destabilized, better stabilize it. But avoid that better, you try to do that. So pars or pars violation, facet violation leads to instability and listhesis. Then too much of bone removal, I think, you want to be very cautious. If you remove minimal amount of bone, probably persistent symptoms will be there. For the safety sake, you remove too much of bone, probably you instability like this later. This is the case where the decompression laminectomy done, subsequently destabilize, the surgeon destabilize that, and this is the end result. So what you ought to remove that. For that, you read an MRI and CT if necessary, correlate, and then plan before decompressing. Plan yourself what you are going to remove, whether you do open surgery or minimally invasive. Plan yourself and make it a point what to remove, and then you remove that. So remove what you ought to remove. So the algorithm for a regular conventional surgery, the commonest claudication pain, you do a laminectomy. And when there is associated leg pain, you do a facetectomy, unilateral or bilateral. And then because all these things has to be done, plevectomy, discectomy, osteophytectomy, as per the need of the correlated pathology, knowing very well the morbidity has to be accepted by the surgeon and accepted by the patient himself. And if there is unilateral symptoms like this, you see there is only one half of these going for unilateral, asymmetrical, which probably, as I told you, may be going for degenerative scoliosis later. But right now, patients have unilateral symptoms. At that time, you can do hemilaminectomy and laminotomy. And then this concept which I told you, in those days when you do, you can answer a laminectomy, we will leave you. Because in those days, in X-ray, we are dependent only on X-ray and myelogram. But now if you say that, we will not agree, because you see before you open up, you see very exactly where is the problem, precise diagnosis because of the advancement of radiology. So see before entering into the pathology entry as a surgery, and then plan yourself what you are going to remove. So advancing radiology made us to understand better the disease, the precise diagnosis, the perfect localization, and advanced surgery. And now not only advancement of radiology, advancement technology now leads on to the pathway of minimally invasive surgery. There's something about minimally invasive surgery. For exam point of view, theoretically, you must know what is minimum, is maximum. That is minimal damage, you get the maximum report. Mainly the idea is to reduce the approach morbidity, approach related morbidity. Because for removing this portion, you remove the entire portion in conventional surgery, which is going to be dead space, scar tissue, back pain. And so this approach-related morbidity is more common in these types of surgeries. So our idea is to relate. So minimally invasive surgery is a target surgery through the anatomical space and cleavages. And then you can do a normal anatomy, not disturbed, and neural decompression adequate and oximal is done. So better or at least equal results than conventional surgery. If you are able to give this, do it. Otherwise, please don't do it. So preserve anatomy to maintain the function. That is very, very important. These are all the potential advantages. It is no more a cosmetic surgery. All the things for want of time and skipping this is regularly given in all books, not only in spine, but also in other joint replacement surgery, the advantages of minimally surgery. You can go and read about it. And why and what endoscopy? If you say I'm going to do conventional endoscopy is not today, day-to-day affair, 2020, which is there in 2000. Percutaneous intradiscal procedures were started. 2005, we have done a scopy for second generation. 2015, which is for disc prolapse. And then it was scopy for canal stenosis. Now, the scopy for interbody fusion also being done in endoscopy. A cell phone you want to update, cash on today. We don't use a smaller cell phone in those days. So don't try to, something like a cell phone which you use an updated one, try to shift the surgery from old one to new one. This is what I have done in my own personal experience. I am lucky enough to be exposed to all these things. I lived in that era where I was seeing open surgery using a loop in 1980s. Then I was switched over to microscope. Then 2005, as Nalli told, I was the first one to start this endoscopy in southern parts of India. And then 2016, I used minimal tubular retractors. 18, I started with percutaneous. And now I started doing full endoscopy. You have to move on. It is a competitive day-to-day life. Unless you update, patients update themselves, they come and ask you, sir, will you do endoscopy? Will you do minimally invasive? That is the knowledge of the patient. They are seeing the media. So the surgeon has to update himself. Otherwise, he will be thrown out from the scene. So these are all the various options of available for a minimally invasive surgery. You see the distant which I used earlier. And then percutaneous screw, which I use now. And then using a tubular retractor. And then full endoscopy translaminar. All these four varieties of surgery based on the posterior interlaminar space. Then you got a full endoscopy transforaminal. You go for a lateral. The disc and the canal, the foramen can be through the lateral. This is just for the postgraduate. They may ask you full endoscopy translaminar. You must be able to write something on it. So majority of the surgery, minimally invasive surgery, are based on posterior, and a part almost 20% based on the lateral aspect. Now coming to, once again, there are various techniques. These are all the words you must know. I just mentioned for want of time. Interlaminar surgeries can be destined to or full endoscopy interlaminar or full endoscopy translaminar. And this translaminar, it can be outside in. You can approach the foramen, go into the disc, or you can enter into the disc and then go in to reach the spinal canal. That is called the inside out technique. They may ask something like a meniscal repair, they call in and out and in. The same thing has come into this place, transforaminal. So you must know all these types of words and do it. But whether you do open surgery or endoscopic surgery, where to start, that is very important. Otherwise, because the already canal is narrowed, if you start somewhere, probably you'll end up in trouble. Because the area where you start, safe area is go to the medial side, come to the foramen, start with that, and then go proximally along the lamina where it is attached, the ligament of flavum is attached to that, clear that area. And then you can come down. It is going to be unilateral, central stenosis with the unilateral symptoms. You come down to see the osteophytes of the partial facet on this superior ascending facet, and then go in lateral, then finally you do the ligament of flavum. And we always, majority of the surgeons keep the ligament of flavum till the end because to avoid the damage in neural structures when you operate on a bony structures. So this is the pattern which you go. This can be adopted whether you do open or not. If you adopt this step, probably you may not have problems of a neural injury. Then coming to the bilateral symptoms. We are approaching now the unilateral approach and the bilateral decompression we used to. Whether full endoscopy or distant or bilateral, you do over the top technique. You decompress on one side, go underneath the lamina and then do a decompression on the other side. So in the meantime, you keep the ligamentum flavum inside, but some technique, they remove the ligamentum earlier and then go to the opposite side. So ultimately, after your surgery, the picture should be like this. The lamina is gone, inferior margin, the medial facetectomy, a portion has been removed, and then the lateral region, the lateral nerve root has been seen, and this is there on the other side, and this is there. This is a bilateral overtop technique. Whether it is an overtop technique, open or minimally invasive, you should decompress like this. And this is, I thought I'll skip the video because time is there. Time is not there. So this is the video. I have done a lumbar canal stenosis over the endoscope. This is one side. I am just skipping the video. I'm going to the other side. This is the opposite ligament of flavum. I'm chasing that. You see this one. This is the advantage of the endoscopy. You can see the tip of the instrument, which you cannot see in macro surgery or even in microscope, because I can very well confidently say, because I use that also. This much of the cutting edge, what you cut, you can see. You see how nicely. Whereas microscope, it obstructs the vision. That's a controversial issue, which I'm not going into that. But you see, just this is the end part of the surgery. This is one side, tubal border on the other side. This is the tubal border on this side. I am doing a foraminectomy, ligament excision on the other side. And so this is the overtop technique. You can see the nerve root on the other side. And final check. This is the dura, this is the nerve root. And I'll check on the other side. This is the nerve root. So from unilateral approach, you can do a bilateral decompression. That is the advantage of minimally invasive surgery. Then coming to the protocol, predominantly it is in the interlaminar area. When there is a central stenosis on the posterior side, no role for the foraminal technique. You can't reach the posterior side through the transforaminal approach. So pure central stenosis, most of the problems are there on the posterior aspect of the spinal canal, only a translaminar. Whether you use a distant or full endoscopy or biportal, it is always going to be posterior. At the same time, when there is central as well as bilateral, lateral, claudication plus lateral, you can use the same one, all the three types of scope through the interlateral space. When there is additional back pain is there for the patient, you have to think of whether associated instability is there, or is there going to be deformity, or is there a triple D degeneration is going on. Kindly explore on that when the patient complains of back pain. Transforaminal technique, when there is a problem in the center and the anterior side, or a subarticular area, or a foraminal area, or extraforaminal. All these area, that is compression, you can do a transforaminal approach. But limited approach, you can't actually, experts, they do it. Those who regularly do it can reach here from this area. But better not to venture on this, better address the problem which is there close in and around the foramen. You can address very well by the transforaminal approach. And this is just an algorithm for endoscopy. A central one, interlaminar posterior, subarticular, you can venture subarticular and the foraminal, you can use a transforaminal interlaminar. And the extraforaminal, you do a transforaminal approach. And even with the distant do, there is a separate approach is there, we can go for intervertebral also. This is just for a completion's sake. Now next, when do you instrument or when do you fuse? That is very, very important. That is extent of decompression. It all depends on the extent of decompression within the pathology. Extent of decompression you should know, because you have to remove the apex of the ascending facet here to the middle of the pedicle here. This is the area between the two pedicles you have to remove. This is what the superior facet, and this is what has been removed at this area. This is what after minimally invasive decompression we have done through the scope, and this is what the post-op CT. So how much to do it from the apex of the facet and then to the middle of the facet, we have to release whatever that comes on the way. Then this is just, I think, last few slides. When there is an instability is there, I use a percutaneous screw. You see, ultimately after the instrumentation and stabilization, you see the scar is very minimal. So percutaneous stabilization has been done like this. And then I use a tubular retractor diffuse. This is just to show the ultimate incision. These are all for screw. This is for the fusion there like this. So with the minimally invasive, you can do an instrumentation infusion combined with the tubular retractor, combined with the percutaneous screw. This can be done. This is the perioperative C-arm. You see the nicely the caviars are there, and then put in the fusion cliff cage, and then coming back with the final version like this. So LCS with the decompression, instrumentation, infusion has got a role, definitive role. Whether it can be planned preoperatively, you can decide. Yes, you can decide. When there is a demonstrable instability with the dynamic film, or when there is a reduction in this space like this, then you fuse, you increase the foramen, patient will get relieved of the radicular pain, of course, addition to the lateral foraminal release, or when there is a listhesis, or when there is a previous surgery done earlier for the same thing and failback syndrome has come, at that time better plan instrumentation infusion. So preoperatively for a given case, you can plan whether it is instrumentation infusion is done earlier. Now on degenerative scoliosis also. When the next, this is what I wanted to tell you, the angulation of the facets, and this is the angulation of the various facets can come, the more and more it is an acute likely to get into a listhesis. So in those cases where you are going to do a decompression area, likely to compromise on that, when the acute angulation is more, probably it itself will give you a listhesis, and the nature will produce a listhesis and not the surgeon, because the surgeon's fault is not failure to recognize this. If you recognize the angle of the facet, spend some time on it, it is likely to listhesis, better going for instrumentation. Great. That is the orientation and asymmetry. And sometimes when there is an atrophy of the lamina of L5, you don't listen to it, and then you go on to a decompression, bony resection is there, you end up with the pars intraarticularis excision, and then postoperatively you make a instability. So in these occasions, preoperatively, you can decide whether instrumentation is there or not. And then perioperatively, sometimes inadvertently we remove the facet. You go on excising, and then after excising, you will see one facet is missing or pars is missing, because you are interested in go on whatever comes on the way you remove, and finally you do that. So whenever you do a lumbar canal stenosis surgery, you always keep the instrumentation infusion ready with you and do that. I think this is the last part of the slide. This is, I don't want to go into the detail because it itself is a deliberate bigger topic. When it is associated with the scoliosis, the instrumentation and infusion is indicated, and itself is a bigger topic. I'm not going into that. I think those who are all awake and just sleep can just awake for the last few seconds. You can remember this, whatever if I'm told is not relevant. Monosurgical or monosegmental or bisegment stenosis, instability is not there. You can go choose an endoscopy. Instability is there, you can go in for a percutaneous stabilization, tubular retractor, decompression, infusion. Multi-segmental instability, with instability or not, you can go in for two separate incisions, you can go, and then percutaneous stabilization can be done. Or if you want to do conventional surgery without stabilization, you can do an osteotomy spinous process or spinous process treating. Now, finally, whatever surgery you do, please do decompression. If necessary, do instrumentation infusion. The pain reduction by standard procedures has to be done. Whether you do open or miss or fully endoscope or biportal, pain reduction has to be there. Whatever you do, patient do not bother. They want a pain relief. But of course, the advantages of the endoscopy is there. Patient point of view, surgeon point of view, of the cost factor. So you remember, if the conventional surgery is there, that adequate alternative is available, MS, with an evidence, of course, with an experience. So it is a clinically challenging situation. Lumbar canal stenosis, symptoms more than signs, precisely localized before operating, correlated clinical hemorrhage has to be done. Assess the associated instability both preoperatively and perioperatively. And decompression is necessary only to the dynamic part, that is maintain the normal anatomy. And endoscopy miss is the best as far as I am concerned, because I have seen both open surgery and miss. I will vote for miss is the best for lumbar canal stenosis, and choose the option. Don't try to do because somebody is doing. There is always learning curve is there. And stabilization infusion is choice of the, not of the surgeon, but choice on indication. I think with this, once again, I wish you all to be safe and stay safe, be safe, adhere to all precautions, keep away from COVID-19. Thank you so much for the listeners.
Yes, I think, thank you, sir.
Yeah, yeah,
I
yeah.
think that was very clear. The management, as far as the management was concerned, I think you have dealt with that extensively.
Yeah.
And I don't think we need to add anything more than that. I think
Yeah.
I think before conclusion said, everything depends upon the experience of surgeon. Don't do whatever is said because it is said. And you should have the experience also. I think the most important thing that has to be stressed is adequate decompression, and wherever necessary, like for example, if there is instrumentation has to be done, instrumental fusion has to be done, especially in cases of dynamic, and you call it dynamic lumbar canal stenosis, or when you feel that iatrogenically you produce extensive decompression with instability, you got to go in for instrumentation. I think that's what I need to just add up here, sir. Anything else,
Bharani?
Sir, we have a question, sir.
Yeah, still people are awake. People are awake. How?
Yeah, Akhil wants to know how to manage adjacent segment degeneration in spinal fusions.
It itself is a great topic, but whenever there is a demonstrable decompression producing pain, address the problem. That's what simply I like to say. Because if we go into that, I think till tomorrow we can talk. So adjacent segment disease, it is not because of radiology. It is symptomatic. If you are going to be sure whether it is symptom correlated radiology, address the problem.
I think it's been really extensive thing, and I can still see around 50 people still sticking on with us. Yes,
great.
Great.
I think
anyway,
I think probably future 50 spine surgeons are there.
Yes, sir. yeah. Anyway, I take this opportunity to thank the Tamil Nadu Orthopedic Association, sir. Yeah, I think yes, sir. You can thank them.
I think the conference is in the fact end only 3 or 4 people will be there. The speaker, the chairperson, and then the slide maker. I think here, office bearers you can add up, they will be there. I'm happy that 50 more is there. Once again, before shutdown, I thank all the TNOA office, again, the members and all the office bearers, and then my who has spent time with me, the moderators, the Nalli, Yuvaraj, and Bharani. Thank you one and all. And thank you so much. Meet again somewhere sometime, but be safe. Thank you.
Thank you. Thank you.
Yeah, patient Danapan, take over.